And here we are. I can't hear you. It says
Can you hear me?
muted. Yep, you were muted. Can you hear me?
Can you try calling me in? I'll go out. Can you see if calling me in works instead?
Okay, no worries.
Thank you. And I'm trying going in through NHS email.
I tried a different email address and then it managed to get you.
I'm on now, thank you. It's just what we need last minute, isn't it?
Yeah.
Hi, John. Hello.
Hello.
Hi, you all right?
Yeah, I am all right.
Good. We can't see
Yeah.
you. Do you have a camera?
Yeah.
Are you happy to have it on?
Yeah.
Hi. We're a few minutes early, but just nice to say hello to people who are here, and then we'll do some introductions in the chat bar, if that's okay.
Yeah. Okay.
If you don't
How's your
mind,
day
just
going?
bear with us a minute. Can we just trial getting the presentation?
Yeah. Okay. It's all right. Yeah. I am little bit early today because I am off now. That's why.
That's okay. That's okay.
Oh,
Yeah.
fabulous.
I just want to have a little trial here.
Yeah. Okay.
This technology is not my thing, so
Yeah. We're nurses, not IT people.
So let me see if I can share my screen. And can you see anything?
We can see
Yeah,
your
we can see the slide.
presentation.
Yeah.
Yep.
But we can
Very
see
nice.
the whole thing. So if you go down the bottom next to the volume horizontal line.
Yep.
Yep, and click, that.
Yep.
See if that changes it. That should change it to PowerPoint presentation.
Ooh. Okay, what can you see now?
Exactly the same. That didn't work.
Right, let me try something else. Hold on.
Oh, Tracy's asking for the link. I'll just save the.
Yeah.
Oh no, it's not.
Hold on.
Hi, Bav.
Hi.
We're playing the same game, trying to get so the little I got in. I'm having trouble with my laptop today, but I got in. Try the one at the top. See where? Yeah.
That one?
Yeah. See if that works.
From the beginning. Oh no. What can you see now?
Still the same.
No.
Right.
I'll
Go
tell you
along
why.
from that. Oh, go on, Bav.
So, you know when you share your screen, Sarah?
Yep.
Hang on. Let me just do. So when you press share in the top right hand corner,
Yep.
you should share the screen, not the window.
Right, let me stop sharing a minute.
Yeah, stop sharing.
I'll go back. So if I click on this one,
Yeah, it's done.
that one? Yep.
That
Perfect.
works.
Right. Okay. If you can just bear with me, I'm going to go on mute because I'm going to get one of my
It's fine.
CPs on the call as well. All right. So I'll be back in a sec.
No worries.
Hi, Tracy.
Hello.
Hello, you all right?
Yeah, good, thank you.
Good. We'll just wait until 2 and then make a start.
Lovely.
If people are happy to, there's the chat facility up the top. I'll ask everybody to just introduce themselves on the chat facility, if that's okay, when we get going.
Okay.
Right, very small group so far today. We'll just do give it one more minute and then we'll do some quick introductions and get going.
So I've just joined Shanti on my phone, so she'll come up as me for the certificate. Sorry.
That
It's
is
a
going
bit-
to confuse us. 2 Sarahs.
Double trouble.
Pretty impressive.
Considering this wasn't going to be me, I think we're doing well to just get on the call. We're good. We're good.
We're good. So should we make a start? There's very few people here compared to normal, but it has just gone 2, so we'll make a start and hopefully some more people might join us. But thank you for joining today. Welcome. This is our 4th forum, isn't it, Sarah? Yeah, our 4th forum for Devon Care Homes Collaboratives. And we've got, as you know, today it's about pain management and specifically pain in dementia. As usual, just please be mindful that the session is being recorded But the whole purpose of the session is about shared learning, an opportunity to discuss with peers how things work in different homes, and just share that best practice or any challenges we're having, enablers that people have found to help. Just that opportunity to really share that best practice, which is so important when we're working all over the place, different bases. So if you're happy to, what would be lovely is in the chat bar, just write your name and who you are, and any information that you'd like to share. I'll be really lazy and just tell you who I am and then ask Sarah to do the same. So I'm a registered nurse and a specialist community public health nurse and a nurse prescriber, a few other things. I've worked in the NHS for almost 40 years, just come out of the NHS, and I'm so pleased to be doing some work with care homes and social care. I did a little bit during COVID and it was just very humbling. And I was very excited to come back and work with care homes again. So, Sarah, I'll let you introduce yourself. We've got a bit of a mishmash today because we've been asking people who have a specific interest or special knowledge in any areas to please volunteer to do a bit of presentation or talk about their area of interest. Lucy Herneman had very kindly agreed to do one around pain specifically in dementia, but unfortunately she just can't be here today. So she's very kindly given us a presentation, which I will share. Sarah has given some more information. She's done a few of the sort of generic slides around that. And then we'll do sort of questions and answers. And I say that really, really important shared learning, challenges that people have had, resolutions others may be able to suggest, and that sharing of best practice if everybody's happy with that. So those who've been before will recognise Sarah, who has kindly stepped in again to do the generic part about the pain management in homes. And please do come forward. We're really keen to have different people come and offer to sort of start the conversation going. You don't have to be expert in anything, just be passionate about it, just be something that you'd like us to be discussing and you think would be of real benefit. The numbers are small today, and one thing we were going to do is actually have a quick discussion about the format, and is the format right and is the timing right, and should we be more specific in topic areas rather than trying to be so broad. So we will finish at least 5 minutes early to ask you to complete the feedback forms. And also please just have a think about the general format and what you think may or may not be useful. But welcome everybody, a few more joining, which is fantastic. I say, please just introduce yourselves in the chat. If you do introduce yourself in the chat, I'm hoping that means you'd also be happy for me to use your email to send you calendar invites for further forums. No obligations to attend, but we can't BCC the team's invites. So I just would like to know that people are happy that I'm putting their emails on those invites. But anyway, thank you. And Sarah, are you happy that I hand over to you to introduce yourself and the slides that you've kindly put together for us?
Yeah, can I just ask, is it still sharing or has it stopped?
It's stopped, which was lovely to see people, but yeah, you'll need to do it all again, I'm afraid.
Right, I'll introduce myself first. So for those of you that I haven't met before or that you don't know, my name is Sarah. Hold on a second, can we mute that? It's going to echo if you can. Sorry guys, we're having a bit of a technical issue here. Okay, so my name is Sarah. I'm a registered nurse of 40 years and many of those have been spent in social care, and I'm currently a home manager for Evolve Care Group, and I also do clinical teaching for Indago development as well. So juggling a few hats, and happy to step in and help Anne out today with the presentation. So first of all, I'm just going to do a broad introduction into pain recognition tools. So if you can bear with me while I get the slideshow back up again. I think this is the right screen. If someone can tell me, can you see the whole screen? Good, good. Okay, so we're going to look specifically, there are a lot of tools, but we're going to look specifically at the tools that we use in the social care setting. So there are a number, and depending on your background, length of time in a clinical setting, either as a care practitioner or as a nurse, you probably come across a few variations. But I've jumped on the British Geriatric Society and just picked out the main ones that that they mention in relation to geriatric care. So the first one that comes up is the numeric rating scale. Now, although today we are going to talk primarily about dementia, as you're all aware, not all care homes have people with advanced dementia. So, you know, some people are able to self-report pain. So it's important that we do have access to another tool that may be relevant. And this one is widely used in residential care. It's also widely used with people who have the verbal ability and the physical ability either point to pain or to verbalize it. And literally, it's as easy as you can see by the demonstration on the screen. It's a score of 0 to 10, with 0 being none or very mild pain, down to 10 being the worst pain ever. And that can then be interpreted by the clinician, whether that's a care practitioner or qualified nurse, and the appropriate plan of treatment escalated from there. So pretty straight forward there. The next one is the Abbey Pain Scale. Again, many of you may have come across this. So this is an observational tool which looks at 6 key areas. As you can see from the demonstration on the side, it's quite easy. You're literally choosing from it, looking at each individual section. So if we look at vocalization, so whimpering, groaning, crying, if it's absent, it's a 0, mild 1, moderate 2, severe 3. You're going to put your scores in the box down the side here. Work your way down answering the questions. The total pain score will indicate the measure of the pain at the bottom. So 0 to 2, 3 to 7, 7 to 13 or 14 and above. And you also need to consider from a clinical perspective whether you feel that this pain that you're assessing is an acute pain, chronic, or acute on chronic. So whether you look at the comorbidities of the person in front of you, so we may have chronic arthritis, we could have pre-existing back conditions, neck conditions, joint conditions. Acute could be someone who's had a recent surgery or a wound. So pain around, you know, wounds could come into there as well. So there's quite a few variations that it gives you. And again, it is another widely used tool in the care home setting. And it's useful because it is simple and it takes out some of the ambiguity in assessing pain, which is one of the main issues that clinicians come up against. So what we need to remember about pain is that it can be subjective. It's often underassessed and often left unrelieved, especially in dementia, because it isn't recognized and the and inappropriate or no courses of actions are taken in the appropriate time frame. Assessment in our setting can be very complex, but pain should always be a priority for the clinical team on duty. It can be influenced by many factors, and that's why the use of a proven tool is so important. And nurses have to be able to interpret the score to support care practitioners or their team members and make sure that the type of medication, if it's you know, pain score that indicates that medication is required, that the appropriate medication is administered, or some non-medicinal action taken, which might be a repositioning, or it might be a topical cream application. Whatever it is, it's down to the registered nurse to make that plan of action. Many care plans and MAR charts will have prescribed first, second or third line analgesia, so that the nurse has got a choice of remedies to go to. So before we go into the main presentation today, it's important that we know that pain assessment tools have been developed. There are many. We've touched on a couple there. They each have their own specific attributes and relevance in clinical practice. And the use of a tool is advantageous, and we should encourage them to be widely used. Now, in complex and dementia care, primarily we look at a tool called PainAd, and I'm going to hand her over to Anne now, who has got Lucy's presentation on the use of PainAd in dementia care, and then we could go into a discussion on that afterwards. So I'll just stop sharing there. Has mine gone? Good. You're on mute, Anne.
And now she's disappeared. I think she's probably pressed the wrong button.
Okay. Oh, she's coming back.
She's back.
I am so sorry. IT challenges. Right, I will just try again to share and let me know. Now it's disappeared because I had it. I was trying to put it across when I lost you. So just give me one sec. Can we just, is there any questions or any observations from what Sarah was saying there while I'm just pulling up the presentation from Lucy again? Any specifics around the other pain tools? So not just the PainAd, which we'll go on to, but do people use many of the other pain tools that was being discussed? I know obviously the smiley faces, the 1 to 10 is really common. Is that one that most people use at some point?
If not, it might be
Yes.
useful for discussion at the end. If people pop in the chat bar, any of
Yeah,
the tools that either we've mentioned that they've used or any others that they may have come across, you know, in clinical practice.
Absolutely. Right, I'm going to try and share my screen in a different way because when I tried to share the presentation, I just came out. So excuse me just a minute. Are you seeing my, well, Lucy's presentation?
We're seeing all of it though with the slides down the side.
Okay, let me just try and. Is that better?
Yep.
Right, so as I say, Lucy Herneman very kindly did this. Lucy's a registered nurse at Hinton Nursing Home, and she's got a particular interest in identifying pain in dementia. Really kindly offered to share a slideshow with us, even though sadly she can't be here today, but this is all her work. So I will just talk through it, and obviously we'll be sharing these slides afterwards. So obviously all the research shows, as I'm sure everybody knows, that pain is under-recognised and under-treated when people have severe dementia. Behaviours can make it very difficult to interpret pain when people have dementia, particularly if they have any sort of tendency towards physical or verbal aggression anyhow. And then if they are finding it hard to express pain and do become physically or verbally aggressive, it can be presumed it's deterioration with the dementia, and it's a new challenge that they've got with the dementia. Obviously, identifying that there is pain, if that is the case, is the first step in actually effectively managing that pain. So as Sarah was saying, PainAd is a tool which is used particularly for people with any sort of cognitive, I've obviously got one, cognitive challenge. And you need to observe them for a period of 5 minutes doing different activities, whatever those activities would normally be for that resident. So personal care, they could be resting, they could be doing activities, whatever they would normally be doing, or whatever they're doing at the time that you're worried there may be some pain showing through there. A scoring system is then used of those observations to determine what level of pain that resident might be suffering with. It's not a fail-safe, because obviously observing people and interpreting it is subjective. And also it's really important that we consider other things as well. So whereas we're saying we must consider pain when people aren't necessarily vocalizing they've got pain, we must also be considering things which can mask similar symptoms such as urinary tract infections and constipation. So this is the PainAd tool. Looking at, again, it's quite a simple scoring system. Observe for 5 minutes, look at breathing, vocalization, facial expressions, body language and consolability, and then scored from 0 up till 2 and totaled. So the breathing, is the breathing normal for that person? Obviously, we may have many residents with chronic obstructive pulmonary disease or different challenges with breathing, but is that breathing normal for them? Is there occasional laboured breathing? Characterised by episodic bursts of harsh, difficult or wheezing respirations? Are there any short periods of hyperventilation? So, for example, rapid deep breaths that lasting a short period of time. Is there any noisy or laboured breathing? Any unusual sounding breaths for that person? I say mindful of their medical history. But when they're either on inspiration or expiration, are there any sort of loud gurgling noises, wheezing? Do they appear to be strenuous, having to be strenuous? Are they using those additional chest muscles, the accessory muscles, breathing in and out? Are you seeing a pitting there under the sternum? The long periods of hyperventilation, which, as I'm sure you know, is characterised by an excessive rate and depth of respirations, which can be lasting a considerable amount of time. And then the Cheyne-Stokes, which we here, as the sort of end stages of challenges with breathing, where they're characterized by the rhythmic sort of waxing and waning of breathing from a very deep, slow and shallow respirations to periods of complete apnea where there's no breathing at all. The negative vocalizations, which is the first part of that chart that we looked at, and we will be, most of you are probably familiar with the PainAd, but we will be sharing the slides which showed that. So none is where the speech or vocalization is neutral, quite pleasant, quite normal for that resident. An occasional moan or groan characterized by a kind of mournful or murmuring sound, wails, groaning, louder than usual, inarticulate, involuntary sounds, often abruptly beginning and ending. And all of this is why it's so important that you really do observe the resident for 5 minutes, because these won't necessarily be constant, but we need to be aware of where, if there is any negative vocalization, how you would score that. If there's low-level speech with negative or disapproving quality, such as muttering, mumbling, whining, grumbling, or swearing, it could be complaining, sarcastic, there could be a caustic tone. It could be the way that people who are suffering with dementia are trying to vocalize that they just don't feel good and they're in pain. There could be repeated trouble calling out, phrases or word being used over and over in a tone which is an anxious tone, uneasy, suggests distress. It can be loud moaning or groaning with murmuring sounds, wails, much louder than that person's usual volume. And the loud groaning is characterised by louder than usual inarticulate involuntary sounds. Often suddenly stopping and starting can be a sign of the pain taking hold. And then crying, obviously, if there may or may not be tears, it could be sobbing, it could be quite weeping, but that's indicative that obviously that resident is suffering. Facial expressions, really important, and this is where in care homes you've got real advantage over like in hospitals and acute facilities, because you know your residents really well. So you know their normal facial expressions, you know what usually makes them happy, you know what doesn't make them happy. So they would score 1 if they're smiling or inexpressive. So even with people who aren't able to communicate well, the obvious signs of the upturned corners of the mouth, the brightening of the eyes, looking happy, looking content. Inexpressive is the neutral, at ease, released or relaxed or blank look. Then sad, characterised naturally by sort of unhappy, lonesome, sorrowful or dejected look. There could be tears in the eyes. Again, they may not say anything, but you know, just looking closely at that person and monitoring, do their eyes look, you know, sad? Do they look unhappy? Do they look sorrowful? Frightened would score a 3. You know, that's characterised by a look of fear, alarm or heightened anxiety. The eyes are wide open. Obviously, particularly for people who have challenges with communicating, being in pain would be quite scary, would be quite frightening, and seeing that fear on people's faces can be very telling. Frown, the downward turn to the mouth, increased wrinkling across the forehead and around the mouth may appear, or even worse, the facial grimacing. If you see a sort of distorted or distressed look, the brow even more wrinkled, and the mouth, the eyes could be squeezed shut. That's usually obviously indicative that there's something quite wrong for that person at that time. The body language. So obviously if somebody's relaxed, it suggests if they're calm, they seem to be taking it easy, it would suggest there's nothing too significant ailing them at that time. If they're tense, which characterised by strained, apprehensive or a worried appearance, that can be suggestive that, you know, there's something wrong, which could be pain. The jaw may be quite tightly clenched. Distressed pacing. Obviously, people with dementia do a lot of pacing, but if they seem more unsettled than usual, if they appear fearful, worried, there could be that disturbed element present. It may be faster or slower than they would usually mobilise. It's knowing again your residents. That's where your knowledge of your individual residents is so important, and actually doing that full 5 minutes of monitoring to understand where they're at with their movements, their body language. Are they fidgeting, the restless movements, squirming or wriggling in the chair, particularly if that's not usual for them? Could be hitching a chair across the room, repetitive touching, tugging, rubbing body parts. As we say, really important to be considering any other potential reasons, such as infections, UTIs, but it could be pain. Could be pain because of one of those reasons, could be pain for so many reasons. And if they've gone rigid, you know, we all tend to, if you're in a lot of pain, I've just been to the dentist, you know, when you're anticipating pain, you're in a lot of pain, you tend to sort of become quite tense, arms and legs tight. The main body may be difficult to support them with relaxing into a chair or moving around. Fists clenched, obviously quite an obvious sign that somebody is not at ease and there's something wrong. So if their hands are tightly closed or if they're opening and closing them. If they're sat and their knees are pulled up, particularly if the knees are pulled right up to the chest. Obviously, as Lucy has said, exclude any contractures. You know, are there other physical reasons, medical reasons why that's happening? But if they're not normally suffering with challenges with contractures, and if they're sitting there with some of these facial expressions we've talked about and they're pulling their knees up to the chest, again, highly indicative that they could be in pain. And pulling or pushing away. The person could be trying to escape or wrench himself free or shoving you away. Again, it's easy to misinterpret signs like that as general dementia, distress and aggression. But is there a reason why that person's doing that? If they're in a situation where they'd usually be relatively calm, or if they're doing it more than they usually would, why they're doing it, and always consider, is that person in pain? It's difficult behaviour to see and to manage, but even worse for them if it's because they're suffering pain and they just can't vocalise that to us. And then obviously striking out. So hitting, kicking, grabbing, any sort of personal assault. Hopefully, if it's because it's pain related, we would have seen that before it escalated to that stage, although obviously people can suddenly be in acute sudden pain. But if a resident is hitting out, punching, shouting, why? You know, pain could be the reason behind that, or part of the reason behind that. And then how easy is it to console them? If there's no consolation needed, they seem quite well, they're content, great. If they're distracted or reassured by voice or touch, when spoken to, that if the behaviour stops during a period of interaction with no indication that the person is distressed, hopefully at worst they're sort of looking at mild pain. But if we're unable to console them, distract them or reassure them, no soothing is stopping a behaviour we're usually anticipating able to stop, there's no amount of comforting, verbal or physical, to alleviate that behaviour, that's suggestive that there's a real problem for that person at that moment in time. And say that's again why that 5 minutes of observing the person, if appropriate, obviously not if they're hitting out, but is really important. So again, just going back to that breathing and the scoring, you've got, this is the pain ad, really helpful, say for people with anybody with cognitive challenges, but especially with dementia. So the breathing, as Lucy had set out, is it independent of vocalization? Is there occasional laboured breathing, short periods of hyperventilation, or some of the higher areas of concern would score a 2, where there's noisy laboured breathing, long periods of hyperventilation, or the chain stoking. So obviously you'd score there 0 to 2. Again, for the negative vocalizations, none, great, no score. The moaning or groaning, low levels of speech with negative or disapproving quality would score a 1. And repeated trouble calling out, the moaning, the groaning or the crying would score the 2 there. Facial expression, the same. Sad, frightened, frown, likely indicative of pain. Facial grimacing, very likely to be that there's pain and it should be considered seriously. The body language, again, relaxed, no score. You can read all this yourselves, but you know, if they're rigid, they've got their fists clenched, they're pulling or pushing away or striking out, that's of a real concern and maybe highly indicative that they're suffering with some pain. Same with the consolability. And then obviously total up the score. So as Lucy's put here, there's each domain's documented the scores given, as well as an explanation as to how the person displays those signs. So for the care notes, you'd want to be explaining what that looked like, especially, you know, for the continuity of care, for handovers, for other staff coming on, especially if it's staff who may not know that resident so well. So the scorings there for the breathing, the vocalization, facial expressions, body language, consolability. If there's a score of 7, that's indicative of severe pain and PRN should be considered. So what does the score mean? So the total scores range from 0 to 10. So 1 to 3 is indicative that your resident is in mild pain. 4 to 6 is indicative they're in moderate pain, and 7 to 10 is indicative that they're suffering with severe pain. and medication then can be given with good rationale and good reason. So I will stop showing. Yep, has that worked? Has that disappeared? Everyone back? Yeah. So thank you to Lucy for that. Oh no, I'm still showing.
It's still showing.
Is that gone?
Yep.
Yes.
Fantastic. So thank you so much to Lucy for sharing that. She does a lot of work around pain management with dementia, and she's very happy to contact people, discuss with people about that and her knowledge, which is great because, as we keep saying, this is all about shared learning. But what we'd really like to do is just have a bit of a discussion about what tools people do use, what they do find that's really beneficial, how they record and how they report the pain, just again for that shared learning, shared experience. And also, if it's okay, I'd say to anyone who does have a camera, would you please put your cameras on, because it's much easier to have those conversations if we can see each other's faces, even if it's only across a screen. Thank you so much. Sarah, that really is clever. You're appearing twice.
I know.
It's brilliant. So yes, are there any sort of questions to kick off? I mean, we have some sort of points that we'd like to consider and look at with you all, but are there any questions from those PowerPoints? Do most people use PainOut with residents with dementia? Do they use the other tools that Sarah was sharing? I'm muting now to encourage someone else to speak. I'm going to pick on you, Tracy, because it keeps looking like you're saying something, but your microphone's flashing on and off.
Hello.
Yeah,
that was really interesting. We don't actually use that tool here. We haven't got a lot of residents here with dementia. So that one's quite useful to use. We normally just use the Abbey Pain score tool.
How do your teams find the use of that? Do they find that it gives consistent information? Because as we said, it can be, two different people can complete the pain score and come up with a different interpretation.
Yeah, that is true. Quite often we just say sort of what is your pain between 0 and 10, and let just the resident answer, and then we go from there. But this tool that's just come up here, which we don't use, I will be implementing that for people with dementia. I think that's quite a useful one.
I think from a professional point of view as well, when we have to be making the decision on the action that we're going to take, whether that's the first, second or third line analgesia, whether we're going to try repositioning, whether we're going to try a topical application of heat or cold, or an anti-inflammatory gel, or whatever may be available in our toolkit.
Yeah,
for the clinician to have evidence as the rationale to record, I used the Abbey pain scale, the score was 5, my action was this. It just helps with that evidence-based approach to decision making.
Yeah, absolutely. I agree.
Thanks, Tracy. What about anyone else? Do you use the same sort of tools? Do you have any challenges or found real benefits with them? We can't hear you, Jimini.
In our care home, they are using the pain ad assessment. I saw. I am working as a care assistant because I got just a PIN number. So I saw they are taking the pain ad score and everything. So only once we will take this pain ad, or any duration is there?
Are you asking?
Is there any duration for the pain ad? Only once only we are taking, or how many times we are taking? Only one time, no?
So usually with a pain ad, so if you have a person who has dementia and you cannot rely on them to indicate pain reliably, you would have a baseline pain ad when they first come to you, or as soon as possible after they settle. If you had an episode where they were agitated or there were behavior changes, you would complete a pain ad. From the pain ad, you would indicate, you might say, right, well, the score was between 1 and 3. We're going to start with some paracetamol. Then best practice is to repeat it after 30 minutes after you've given the paracetamol, because you also need to record the efficacy of the medication that you've given, because you are forming a record for the GP or for any healthcare professionals that are involved to review that. Because if you had consistent pain ads where paracetamol was not relieving pain, there is clear indication there that something else or another action is required. Maybe a second line medication, maybe there is the need for different type of chair or different positioning in a profiling bed. It could take you on a journey to pain management that is not based on medication, but is supported by other physical factors. It can also be supported by other psychological and emotional factors. There may be triggers around the person that is triggering a behavior that indicates pain, but it may not be pain. So it encourages you to look at the person at the center and then broaden that out to influences that may either be causing pain or mimicking pain in their behaviors. If someone is on second or third line analgesia, you would be looking to complete a pain ad before and after the administration of regular analgesia. Again, you're trying to get that evidence-based approach for the professionals involved in their care to make sure that they have the appropriate medications available to them.
Okay, thank you.
That's okay.
And also, Sarah, is it common practice in care homes, because apologies, I'm relatively new to it with care homes, but to have residents' families involved with that initial assessment if possible? So being able to do that pain ad score while you're with them as well, to ask them what they would normally anticipate from their relatives and what they see as abnormal behaviour.
Best practice specific around pain ad is that if possible, get a baseline on admission day. Now, often that may not be a true indication because people can be anxious, disorientated, depending on how far they've travelled, where they've come from, whether there's a family member, relative, friend with them. Compare that with day 2 and day 7 so that you can start to build a picture of, how they are settling, because, it's important to monitor that journey for someone, and pain can be a real problem. If someone has been in an ambulance for 2 hours to get to you, it can take them 7 days to recover from that, especially if they've been on a stretcher. So, if they've got underlying, arthritic changes, that kind of thing. So the gathering of data around pain has to be ongoing. So then, as you said, what is normal? What is normal presentations? And that's where your relatives, your friends, the people that know them, maybe district nurses that have cared for them at home, they can give you really crucial information about how pain may have been presented in the community, how pain as an adult prior to any onset of disease process or dementia, pain thresholds are different for everybody. If it's someone who's had a few children, experienced in childbirth, may have a very high pain threshold. You may have someone else who will be extremely distressed if they stub their toe. So it's like it is very subjective, and the more information and the more clarity you can get around how they may or may not present. You know, one example I always use for people is sometimes people just cry. Now, you don't know, crying could be someone's upset, but it can be pain because they don't know how else to tell you that they are hurting. So we have to look at whichever pain tool you're going to use, look at what's in front of you, and this powerful tool that we have to observe people when they are seemingly not in pain, and then when they are suffering some form of distress, helps us to build that picture, to really put the person at the center of all of the care and assessment that we complete.
Yeah, that's great. Thanks, Sarah. And is there any other learning anybody else could share about how they have witnessed and observed pain and how they've been able to maybe alter care plans as a result of that, or implement best practice for that particular resident? It would be great to kind of share knowledge between ourselves. Elizabeth's just typing something. Oh, okay, thanks. Bye.
Thanks, Liz.
Yeah, is there, and Emily, maybe if I could ask you, because obviously you're seeing people in different care homes, are there any tools that you've witnessed that people particularly find more beneficial? Does it absolutely depend on the residents that they have? I suppose the important thing, as we were saying, is continuity, knowing your residents and using some sort of pain assessment tool regularly, updating in the care plans regularly on that pain assessment tool. But yeah, I just wondered, Emily, being in and out of different care homes, if you've seen any sort of interesting different practices.
I can't say that I've especially seen many kind of pain scales as such, but I think, like you say, a massive part of assessing pain, especially in people living with dementia, is really knowing each individual and how they communicate their needs, especially as dementia advances and people's communication becomes less and less. It's really important to understand those cues and those sort of early signs that things are happening before things escalate. And like, Sarah was saying earlier, kind of finding those non-pharmacological ways of intervening and supporting people can be really helpful. And I know from my own personal experience, I found that the biggest help for me was working really closely with other professionals. So I did a lot working with the older people's mental health team and things like that, and just asking for their expertise, learning from them, and then trying to apply that in all the different situations, I think was the biggest thing that I found. And just asking for help if I wasn't sure. But for me, the real thing, I think, is just really getting to know your residents. And a lot of, care staff especially are experts in the people they care for and know all these little bits of behaviour. And it's just really important that we capture that in the care planning as well, and tying everything together. Yeah, I think it is a challenge, especially for people living with dementia, because everybody's experience is so different that it's really a case of just understanding what we're looking for and what support works for that person, I think, if that's any help.
Yeah.
Yeah,
I was
definitely. Sorry, go ahead, Sarah.
I was just going to add in there, Emily, you just reminded me of something that, a pain ad for someone with dementia is a good tool when you can, obviously see someone's distressed and you can sit, observe them, or sometimes you need two people to observe them because they may be agitated and walking around, and so you're trying to maintain their safety, but you're also trying to get a really good look at what's going on. One of the challenges is when people experience some form of a trauma, so they might have a fall, or they might have an altercation, with another resident, where it's quite obvious someone has become hurt, but it's not always easy to see who is hurt and in what form are they hurt. You know, when, you know, people lash out at each other, or if someone has a fall and they're on the floor, they become distressed because they're on the floor. 5 minutes to observe somebody can seem like a lifetime, when you're also trying to manage the falls process, you know, to, you know, check for injuries, you know, make sure there's no bleeding, any skin tears, bruising, that kind of thing. So sometimes, in my experience, you have to adopt a sort of a multi-tool approach. So in essence, you're going to look at using and recording the pain ad, but you may also be able to, in a falls situation, say, you know, do you have any pain anywhere? And although normally that wouldn't be reliable, in a trauma situation, they might rub their leg or they might rub their arm to give you that physical indicator of where you should be looking. So I think we should all be open to adapting the tools, the resources that we've got, and not think, well, you know, okay, I've got to do a pain ad because that's the tool we use. And, you know, yes, it might be your primary tool, but don't exclude the other tools if you don't think that the result is accurate, or there might be other factors at play.
And I guess that's having those resources and those tools and having a selection of them which staff are really familiar with and are happy to use and put into the care plans, isn't it? And as Emily, as you were saying, you know, you want the non-pharmacological options as often as possible, because those are far better for the resident, tend to be far more comforting, whether you're talking about pain or you're talking about music, or whether you're talking about warmth or cold or music or whatever it might be. And also then for that knowledge to pass if those residents do need to go into the acute settings, because if you can confidently say to other staff, right, when this resident is in pain, this really helps her, that really helps her, particularly with all the challenges with polypharmacy. You know, when people are having so many medications, the last thing we want to do is just whack more and more medications into them and all the side effects they're then going to struggle with. So if we know that there's some non-pharmacological resources that really help that individual, that's just got to be better for everybody, hasn't it? Primarily for that individual. So yeah, I would imagine having those tools that staff are really familiar with and are consistent with. So being consistent with the same, I would imagine, Sarah, you know, being as managing a care home, being consistent with the same tools where appropriate, because then you've got that continuity, but also then staff, as you say, having the confidence to say, actually, because of the behaviours, you know, or whatever, we couldn't sit for 5 minutes and we're not sure about those. So actually, we've just tried using, you know, an alternative tool. It's about using the tools, isn't it? Just as a way of understanding and communicating to other people.
Yeah, and I
where
think
that
as
pain's
well,
at.
you know, although ultimately it's going to be the clinician that's going to make the decision based on the score, having the whole team aware of what a pain ad is and how it works and how it's interpreted is really important, because if they stick exactly to the definitions in each section, that builds the picture. But sometimes as the overarching clinician, you've got to actually try and read between the lines there when you're making a decision. You know, if someone has only had paracetamol 2 hours ago, yet they're still distressed, are they distressed for the same reason? So you could repeat your pain ad. Maybe, you know, you've had the paracetamol, initially it might have seemed to work, but now we're escalated again and we don't really know why. It might be a different pain. It might be a different scenario. So as a clinician, we need to be able to reassure ourselves that we've got all the evidence we need to make an informed decision. And with the consistent use of one tool and making sure that the whole team understand what we're looking for and what we're going to do with that information, and recording what else we've done if it appears that, you know, the action we took hasn't been effective. So have they been tried in a chair? Have they been tried back to bed? Have we tried a V pillow? Have we elevated feet? You know, all the different things that we can do, have they all been tried before? As you say, polypharmacy is, you know, one of the major challenges we have in the social care setting before we go escalating again, and potentially having a sedative effect on somebody because we've escalated when that might not actually be what we're dealing with.
And potentially with that, I would imagine could have masked what sometimes may be a new clinical incident for that person,
Yeah.
which could be getting progressively worse.
Yeah.
Brilliant. Thank you. Has anybody got anything they'd particularly like to add into that, or observations around that, or key points to take away from today? Yeah, I can see Bav's typing. So usually Bav puts into the chat bar the the link to the feedback form, but I think there's challenges with that today, is there, Bav?
Yeah, apologies. That's my error. There's I can't send it out. So what I'm going to do is I think we've got people's email addresses. If we don't,
You've gone on to mute, Beth.
apologies. Can we just send an email to?
You're on mute again, Bav. Are you saying email me?
I feel like there's a ghost in my office because my hands are here, so something's clearly happening. If we could,
I think what he's trying to say is, can we
I was
email
going
to
to-
Anne?
definitely here. My hands are definitely here.
We will
It's been one of those
we will get you the
afternoons.
form.
We'll get the form when we
Yeah.
send the resources. We'll attach the form to it, but I believe we might have everybody's. It's just in case there's someone here who hasn't been here, so we can have their email address. But yeah, as previously, Anne will send across your certificate, the resources, and then we'll send a link to the form as well. Thank you.
And could I particularly ask, so obviously this is the smallest number we've had, and we were already talking about the format of these and whether it's useful, whether the topics are too broad, but if we narrow them down, does that mean that there's quite a large number of people it wouldn't be useful for? We'd really like to know what's useful, what's not useful. So what are the topics of interest? Do we need to keep trying as we are to get different presenters to come and talk about different things? We have different presenters lined up for the next few sessions, but just please be brutally honest, because obviously there's absolutely no benefit for your time if we're running the sessions and they're not really of value and they're not relevant. So please do let us know. Maybe it's that we'd be better recording them and putting them out for people to watch, as and when they have the time and the capacity. But the hopes with actually joining for an hour once a month was that people would have that opportunity to do that shared learning. And obviously that's going to be harder to do if we're just suggesting to people, look at these resources, they're really helpful. So please do let us know, please be brutally honest, that's what we need. And yeah, thank you so much for your time. We will finish because we haven't managed to get that feedback to you to complete by 3, which is what we usually do, but I will email them out as soon as we all get off the call. And please do take the time to just really quick, if you haven't done them before, 5 minutes max, and send them back. We'd really appreciate it. Yeah, thanks, Bav's put my email there. So if everyone, in case we don't have theirs, is happy to put it in, that'd be brilliant. Thank you so much, and thank you. It's lovely to see you all today.
Thank you.
Thanks, guys.
Thank you.
Bye bye.
Bye.
Should we come out and, because the recording go on, and have a very quick chat?
So that's all. Come on.
Just someone's typing.
Oh, apologies. Sorry, Jamini. Oh, thank you. Yes, so thank you to Sarah and for Lucy for all their work for that.
Tim Taylor.
Hi, Bav. Sorry, I'll just come out of there. So hang on, I'll put my mic off.